I want to thank all my friends from India, especially Dr. Shashank Shah, for this invitation. It's an honor for me. I am going to talk about the transit bipartition or ileal transposition. I took part in the foundation of short bowel syndrome unit in the 90s. And there we observed that distal resections could be a tragedy, while some proximal resections could even cause some metabolic improvement. The gut hormones were being born at that time. We are starting to understand gut hormones, and we are starting to understand the small bowel as an endocrine organ. They indeed are endocrine organs, but the proximal part is very different from the distal part of the small bowel. In the endocrine activity of the proximal gut, there is a lot of caution to avoid the hypoglycemia, because when you start a meal, you're going to secrete insulin, and there is not too much glucose in your blood because you're starting a meal, you're probably starving before. So in the proximal gut, there is secretion of GIP that provokes insulin and glucagon secretion, which provides gluconeogenesis, a production of glucose in the beginning of a meal with food in the proximal gut. This production is to feed the hungry cells with both insulin and glucose. So this activity does not block gastric emptying, does not cause satiety, does not end a meal, because we are very in the beginning of a meal. But the distal gut is very different. It gives us different hormones like oxyntomodulin, PYY, and GLP-1 that cause satiety, that increase insulin secretion, that block glucagon, that delays gastric emptying, and ends a meal. More recently, it was also understood that FGF19 is a very important hormone. It's not produced by endocrine cells in the intestine. It's produced by common enterocytes, by the mucosa. And it's very much involved in glycemic homeostasis and biliary acids production. And low FGF19 is a predictor of metabolic disease. We know that if we block the FXR, that it's the receptor that provokes the FGF19 production during the absorption of bile in the ileum, the metabolic results of surgery are very much damaged. So FGF19 is really important. So the distal gut that provides also FGF19, it's very efficient in lowering glycemia, in blocking glucagon secretion, and in stopping gastric emptying. It causes a strong satiety, and when properly stimulated, the distal gut ends the meal. In 2003, we proposed that refined modern diet that is too rapidly absorbed in the top caused a proximal hyperactivity and a distal hypoactivity. And we wanted to fix this. We did not understand restriction or malabsorption as the means that these things work. And observing the jejunal-ileal bypass done in the 60s, we could see that in spite of non-exclusion of the proximal gut, there was rapidly disappearance of diabetes. And this is old, this is not new. And later it was recognized that there was a big elevation of distal gut hormones because of the early exposition of the ileum to nutrients. Nutrients in the ileum make you feel and behave like being fed. So only ileal surgeries really provoke high levels of remission in diabetes. But exclusions, they were made for malabsorption, and we do not want malabsorption. Malabsorption is a disease. So we designed bipartitions, many types of bipartitions, but this final aspect was designed in 2003. But I would like to emphasize that only ileal surgeries, and there are many of them, can cause levels of remissions greater than 80%. So nutrients going straight to the ileum is fundamental to obtain potency in metabolic surgeries. What is our transit bipartition? Well, we bring the ileum on 206 or to 3 meters to the antrum, creating a 3 centimeters wide anastomosis in the antrum. Maybe we think of using a bigger one in the super obese. And the common channel we have been enhanced over this time because we understood that the presence of bile is important to obtain the best activity, the endocrine activity of our ileum. So we enhanced it with better outcomes. Typically, most of the food goes to the ileum, especially in the beginning of a meal. Just when the ileum is full, that food starts to go to the proximal gut. All limbs are alimentary, and we have an extended endoscopic access because we have access also to the ileum. This anastomosis drains the stomach. So the intragastric pressure that is high in a sleeve is utilized to push food into the ileum. But we treat this high pressure, avoiding fistula because we alleviate the pressure intragastric, and maybe probably reflux because we lower the intragastric pressure. The presence of the anastomosis fixes the stomach, avoiding coils. So in many ways, the gastroileal anastomosis improve the results of a sleeve gastrectomy. We have a large experience by now. There is no mortality in our team, and it became very, very low in other teams also. There are 0 fistulas in the last 11 years, and we have very high remissions of hypertension, of triglycerides, hypertriglyceridemia, and high cholesterol. There's also a very important remission. But most important of all, we constantly achieve more than 85% of remission in type 2 diabetes without a complete exclusion of the duodenum, like it was shown before with the jejunal-ileal bypass. Weight loss is also very important. So we achieve weight loss that is very similar to duodenal switch. Indeed, it was compared to the duodenal switch by Dr. Topar that came with that TB is obviously faster and a smaller hospital stay. And he obtained just a little bit less weight loss, but he utilized a very large bougie like he does in duodenal switches. And in TBs, we recommend a typical sleeve, not a very loose one. So we tribute this to this fact. And curiously, he obtained the same amount of diabetes remission in TB and duodenal switch with less complications of the duodenal switch. So it seems that TB is potent like a duodenal switch, but with many advantages. We have done a prospective randomized control with a small group of very severely diabetic patients to study the hormones. And we came with a very high elevation of GLP-1 and a modest decrease in GIP. But also a big elevation of FGF19, like I will show you later. And we obtained in the small group 99 out of 10 complete remissions, while in the Stampede at the same 2 years, they obtained a 6 out of 18, 33%. And the DSS study obtained a 35% also. So it seems that ileal surgeries are indeed superior. In this small group, we obtained a remission of hypertension in all of them, and withdrawal of statins in all of them also. Well, other people have studied the transit bipartition, obtained the same kind of numbers we did, like very good weight loss, 95% of excess weight loss, and 94% of diabetes remission. Another study obtaining 85% remission. Another study obtaining 88% of remission in diabetes. And there are even more optimistic studies. In this case, they have obtained 100% remissions in 50 patients with type 2 diabetes with a 1 anastomosis bipartition. There's another study with diabetes resolution in 92%. So I will try to answer your question. Interposition or bipartition? Simplicity means safety, and the bipartition is simple, but we don't do it because it's simple. We do it because it's better. It brings up the whole ileum, not a part of it. And FGF19 needs the absorption of bile to produce FGF19. There is no bile in the transposed part. So I think that it has to be shown that this is able to produce high levels of the FGF19, which is somehow not expected. We can have bile present in the whole ileum if you do a one anastomosis, but in most of it, if you do a bipartition with a very, very long common channel. And we have shown a great elevation of FGF19 in diabetic patients that have this level lows usually. We have shown a 5-fold increase in FGF19. And we observe that there is hypertrophy of the ileum, and it is indeed the mucosa that produces FGF. So a hypertrophy of the mucosa will lead to an enhancement of FGF19, but it's dependent on bile. Well, the bipartition also diminishes the intragastric pressure. It utilizes the intragastric pressure to push food into the ileum. While in the transposition, the pressure might be higher because the ileum is not so propulsive as the jejunum, and this segment cut in both sides is disconnected from the motor waves, the electric motor waves in the beginning, and there is a swollen anastomosis here. So the pressure might get higher in the postoperative period, while in here it's obviously diminished. And this has impacted also in fistulas and reflux, because it's good to alleviate the high pressure of the sleeve. Here we have an enhanced endoscopic access. This is not little, this is important. You have one anastomosis less, one mesenteric defect less, and the procedure is a lot faster than a DS, while this is longer than a duodenal switch. There are not too many direct comparisons between transposition and bipartitions, but there are some. A group from Turkey have compared sleeves with mini gastrics, with bipartitions and transpositions, and they came with a better elevation of blood glucose after bipartitions, a better beta cell response with bipartitions, and they obtained with bipartition the biggest decrease in glycated hemoglobin. And they conclude that duodenal exclusion is not fundamental. Another group have compared bipartition with interposition, and they obtained quite the same results in remission, but they consider TB to be superior because it's simpler. They compared also bipartition with Roux-en-Y gastric bypass, and it's probably better than a Roux-en-Y gastric bypass for obesity and diabetes also. This group had surprisingly came with the conclusion that it's even safer, which we did not expect, but we use the bipartition in substitution to the gastric bypass because we do not want smaller stomachs, we do not believe in restriction, and we don't want exclusions also. And a Roux-en-Y gastric bypass cannot be ileal surgery without causing severe malabsorption. So to conclude, I think that the bipartition is easier and faster, but it's not just this, it's indeed better, with less anastomosis, less mesenteric defects, ileum with bile, a drained stomach, a less risk to the gastric suture, probably less reflux because of the drained stomach, an immediate ileal nutritive exposition and exposition of the whole ileum. So I don't see a clear reason for doing a complex surgery like a transposition if you have a bipartition. The bipartition is probably the best metabolic strategy, both for obesity and diabetes, in my point of view. The sleeve is fantastic, but is not enough for many. And the bipartition is probably the best complement for a sleeve gastrectomy. Thank you very much. A big hug to my friends from India. Have very nice friends there, and I love this place very much. Thank you very much.